Why don't we get started? Thanks everyone for joining us today. It's nice to have a small group, although we really would like to get this out to people in the Hudson Valley, families, ombudsmen, legislators, etc. But please do feel free to use, any information that you learned today, any resources, etc. And of course, letting people know that these recordings will be available on our website and on our YouTube page. By the beginning of next week. Today's program, it's our August update. We're doing this every other month, and I welcome you. If you're not familiar with the Long-Term Care Community Coalition, we are a nonprofit organization entirely dedicated to improving care and quality of life for people in nursing homes and assisted living. And we do that mostly through policy analysis and systems advocacy, as well as being a data resource for the public and for researchers and for policymakers, data on nursing home care and quality, et cetera, which is something we'll talk about a little bit today, focused on the Hudson Valley. We do, over the past 15 years or so, more and more education of consumers and families, long-term care ombudsmen, and other stakeholders. And we are the proud home of two long-term care ombudsman programs in the Hudson Valley, covering the Hudson Valley between north of the Bronx and south of Albany. So I'm very happy to have those programs and to be able to support the Ombudsman's work. Partnering with us is John Rodat. John is an expert on data visualization. A lot of the data that I show, and I think the ability to show it effectively is thanks to John, who's just been a wonderful partner with us, with our data. So today's program, we're going to get started with a discussion on residents' rights, recognizing and addressing abuse and neglect, and then we'll have a data briefing. We'll have a Q&A at the end of the data briefing, but we're going to do something a little bit different for this meeting since we have a guest speaker. Is that when after Deborah Trachowski, our guest speaker, does her presentation, we're going to allow time for Q&A then, and then I'll do the data briefing as I normally do, and we can have some time hopefully for Q&A at the end of that program. So without further ado, I want to introduce our very special guest, Deborah Trachowski. She has dedicated her career to supporting residents and families and to helping who have been victimized, by abuse or neglect or substandard care, and has worked in so many different ways to make care better and to address the concerns of residents and their families. Through her legal practice, she works with residents and quite often the families of residents to try to address situations where there has been abuse or neglect that has resulted in harm, unnecessary harm to residents. But in addition to that, she's been a longtime advocate for nursing home residents and for their families. She has provided many, many trainings and programs over the years for ombudsmen and for other stakeholders on residents' rights, what to do, how to identify abuse and neglect, as she'll be talking a bit about today. She's also been a longtime member of LTCCC's board of directors. I remember Deb came to a meeting of ours and presented. We have a quarterly coalition meeting, and she came, I guess it was like 2004. And after that, I invited Deb to be a member of our board, and she served as our board president since 2014. So again, without further ado, I'm going to stop sharing my screen and hand it over to Deb. Welcome, Deb, and thank you.
Thank you, Richard. Thanks for a very kind introduction. Good morning, everyone. Good to be with you. I'm going to start my screen share. Hopefully. It's not cooperating. Oh, there we go. Okay. Oh, let me just go back a little bit here. Okay. And if you have questions, I'm happy to answer them, but I would ask that you just wait until you can put them in the chat, and I will address them when the presentation is completed. So I love speaking about how to prevent abuse and neglect, because so many of the situations that we hear about from family of residents and residents is preventable. And that's why I really like speaking about it and getting that word out to as many people as I can. So I'll start out with ways to prevent neglect or abuse in a nursing home. And it's important to start with trying to prevent before someone even gets admitted to a nursing home. And what I mean by that is to do your due diligence as much as possible regarding selecting a nursing home. And there are great resources available to find out more information about nursing homes. Medicare.gov, Care Compare, is one site. Also, the LTCC site, nursingHome411.org, has very important information about the history of complaints and inspections regarding nursing homes. Also, staffing indicators. In my opinion, staffing is one of the most important criteria in evaluating a nursing home, because a nursing home may look beautiful, but if they don't have enough staff to actually care for the residents properly, it's impossible for residents to get good care. Also, I suggest visiting the facility unannounced so that you can get a real picture of what that nursing home is like. And not only just visit, but ask to see the unit that your loved one or the resident would be in, because for example, if someone is going into the long-term care unit, that may look very different from short-term care. So that's important. Also, once someone gets admitted, be involved in their care. I know healthcare these days can be very seems like people are very busy, they don't have time for questions, but don't let that deter you from asking questions. Also, attend care plan meetings. You may feel like, wow, I've been to so many, it doesn't really matter, but in my opinion, it does matter. And that care plan meeting is going to set the tone and determine what care your loved one or the resident is going to be receiving. And therefore, you want to know what type of care they're receiving. Also, join the family council meeting. Join the family council and attend meetings. I always feel that there's strength in numbers, and the family council will be a resource that can assist with that. In addition, don't leave the room when a resident is being changed or given care. We hear probably once a week a family tell us that, well, I was told there's a rule that I have to leave the room when my loved one is getting care. And I'm here to tell you there is no such rule. The premise of even the thought of a rule may come from HIPAA, meaning that the resident has a right to privacy when they're being given care. However, if the resident says it's okay to stay in the room, or if the resident is no longer competent and a person is the healthcare agent or the guardian of the person or the surrogate decision maker, and I'll explain what that means a little later, you have a right to be in the room. And the importance of being in the room is that when care is being given, you'll be able to see parts of a person's body that you wouldn't normally see when they're in bed with clothes on or in the chair with clothes on. The important parts of the body to look at would be the low back, the hips, the buttocks, and that is to determine that, make sure there are no pressure ulcers. And I'll talk a little bit more about pressure ulcers in a few minutes. In terms of asking questions, things to ask about would be, what is the resident's diet? Perhaps they should be on a special diet and they're not. Also ask about activities that they're participating in to see that they're taking advantage of the different opportunities that the nursing home would have available. Also ask about medications. And in terms of medications, I suggest asking to see the MARS, which stands for Medication Administration Records. And the reason that's important is because you want to make sure that you know what medications that the resident is on. We've seen situations where residents are on medications for things they may not even need to be on, or they're on psychotropic medications, which are not which are contraindicated for them. And in terms of who can ask for the MARS, again, it would be the same as who can stay in the room. If the resident gives permission, or a person is the healthcare agent, guardian of the person, or surrogate decision maker. Further, if you're concerned about something and you feel like you're not getting adequate answers, don't give up. Ask to see the director of nursing, ask to speak to the administrator. Also, the ombudsman can be very helpful in terms of liaison between you and the nursing home. And go with your gut feeling. If you're concerned about something, don't dismiss it. Don't get frustrated. If your gut feels like something's wrong, keep pursuing it until you get a satisfactory answer. And lastly, in this area, visit the resident as often as possible. I know life is so busy for everyone these days, but visiting, in my opinion, really makes a difference. And the staff know who visits and who doesn't visit. And they even know when people visit. If someone's loved one visits on Wednesdays at 4 o'clock, then that resident may be in their best condition on Wednesdays at 4 o'clock. So it's important to visit different times of day, different days of the week. And it's great if more than one family member can visit, because then you can take turns at different times. So if prevention hasn't unfortunately worked, and abuse or neglect may be happening, then I'd like sharing some ways to identify if it is unfortunately happening. And I break it down into look, listen, and smell. In terms of look for things just are pretty obvious. Is someone being well cared for? If they're not being well cared for, that's unacceptable. Every resident has a right to quality care, and they should be bathed. They should have they should be shaved. Their nails should be trimmed. And if that basic level of care is not happening, that's concerning as to the rest of the care that a resident is receiving. Also, has a resident lost weight? People may think, well, someone has an illness that's progressive and that's why they're losing weight. But that may not be the case. It's important to ask questions about why weight loss has happened. And I'll also talk about nutrition in just a few minutes also. Again, and also looking at the body. Does someone have unexplained bruises or bed sores? If someone is on a blood thinner, they may have bruises, but don't just assume that the bruises are from a blood thinner. Ask questions if you see bruises. And bed sores. Our experts tell us that in most instances, bed sores are preventable. So if you see bed sores, then absolutely something to speak with the facility about. And I'll also talk a little bit more about bed sores later. The next criteria, listen. What is the resident saying? People sometimes think that because someone has some cognitive decline that they're not really a good historian about something or a complaint, but they can be absolutely an important source of information to determine if something is going wrong with the care that they're receiving, or they're not receiving the care that they should be receiving. Also, do you hear the staff engaging in verbal abuse? Perhaps you're visiting your loved one and you're hearing from another room verbal abuse going on. If an aide or a staff member is verbally abusing another resident, it's unlikely they're just verbally abusing one person. And that's completely unacceptable. And that's something that should be reported. Also, listen to the resident in terms of, are they no longer interested in pursuing activities that they used to want to participate in? Again, don't just assume it's because of their decline, either cognitively or physically. It may be because they're afraid of someone who might be performing the activities, or other residents who might be in a common area. So dig deeper if you see a change. And lastly, into this area, smell. Sometimes I will hear someone say, I got off the elevator and I was hit with this strong urine odor. That's unacceptable. Yes, accidents will happen in nursing homes, but it should not be a common occurrence where you step off the elevator and you are experiencing these very foul odors. Also, in the resident's room, If you're smelling something that you haven't smelled before, if someone has a bed sore or that's infected or some other type of infection, that could be the cause of a strong odor. So investigate that. And also, people should not be left unchanged if they have an adult diaper on a regular basis. That's unacceptable. And that is not complying with the regulations regarding quality of care. And that is abuse or neglect if someone is left in a soiled diaper for extended periods of time. And not only is it just inhumane, but it can cause infections and other problems. So, as I mentioned, I'm going to speak about bed sores, pressure ulcers. They go by a lot of different names, but they mean the same thing. So, decubitus ulcers, that also means the same thing. And pressure ulcers aren't really something mysterious. They are very simply a wound or sore that comes from unrelieved pressure. And that's being in one position for too long a period of time. Um, and just I like sharing what we often hear in our office to hopefully prevent another family from having to be in that situation. We hear often that they just found out that their loved one has a bed sore and it's in an advanced stage. Bed sores are staged from 1 to 4, 4 being the most serious. And it's, first of all, the facility should be telling the family when there's a change in condition and the bed sore develops to begin with. Um, and so that's a violation that they're not advising the family until it's an advanced stage. And that's why, as I was mentioning before, to look and stay in the room so that if something is happening, you see it and you can speak to the facility and they can get care and treatment for that to get that healed as soon as possible. Um, and that's also, I sort of touched on the next point. We never knew the resident had bed sores, even though we visited often. Families feel so frustrated that they were visiting and didn't know. And again, that's why it's important to stay in the room and look at the body. And also, we have situations where a resident goes to another facility. Let's say they develop a UTI and they go to the hospital, and the hospital is required to do a full body assessment and they see a bed sore, and the hospital staff tells the family that someone has a bed sore, and that's the first time the family's learning about that. Uh, a common misconception about bed sores is that pressure ulcers will develop because residents are in bed or sitting all day. In the next slide, and a couple slides away, I'll give examples of interventions that can prevent bed sores from developing. So I like to debunk that misconception that if someone's sitting for long periods, they're going to get a bed sore. In our cases, in the litigation that we handle, nursing homes will often claim, and I hear them telling families the same thing, that they were unavoidable because a person has comorbidities, which is basically a name for other illnesses or diseases. And they'll make this claim without addressing what care was or wasn't given to the resident. So that's unacceptable that they're making that claim without demonstrating that what care they actually gave the resident. And along with that, I love sharing that we have very powerful regulations at both state level in New York and the federal level. And we have a whole regulation that deals with quality of care. And there are a lot of subsections regarding the specific type of care or the specific requirements, I should say, for different types of conditions. So, for example, for pressure sores, there is actually a regulation that deals with pressure sores. And I like to read it briefly because it's very powerful. And it basically says that based on the assessment of that resident, that the facility shall ensure, and that's a powerful word, that if a resident enters the facility without pressure sores, that they do not develop pressure sores unless the person's condition demonstrates that they were unavoidable. And this is the important part, despite every reasonable effort to prevent them. And also, point 2 is important because it talks about if a resident has pressure sores and says a resident having pressure sores has to receive the necessary treatment to promote healing, prevent infection, and prevent new sores from developing. Sometimes we'll hear a facility say, well, someone came in with pressure sores, as if there's nothing that can be done. Well, this regulation specifically says they've got to try to heal that bed sore, prevent it from getting worse. So you may be thinking, well, what can actually be done to prevent and heal pressure ulcers? Well, there are several things that our experts share with us. One is pressure reducing or relieving devices, such as there are different types of mattresses that reduce or relieve pressure. There are chair cushions, different types of chair cushions, depending on a resident's needs. Heel booties to cushion the heels so that there isn't that pressure on the heels, wedges to keep it that can go into bed to keep someone off their low back, for example, elbow pads to to protect the elbows. Also, proper incontinence care. If someone is left in a wet or soiled adult diaper, that is absolutely going to have a negative impact on the skin. In addition, proper nutrition and hydration. As our experts share with us, the skin is an organ. And if we don't get proper nutrition or hydration, just like other organs can be affected, the skin can be affected. Further, turning and positioning every 2 hours in bed, every hour in a chair. If someone is physically has an injury, for example, they broke their hip, they're not going to be able to turn themselves as they normally would. Also, sitting in a chair. As you're probably listening to the Zoom, you're moving around in your chair. Again, if someone has a physical disability or cognitively, they don't realize that they've been in the same position for a long period of time, then they're getting significant amounts of pressure to areas in the low back, hips, buttock. Therefore, so if someone can't turn and position themselves, that's an intervention that is very important. So if someone does develop a pressure sore, especially on their buttocks, their low back, it's important to limit their time out of bed to relieve that pressure. I know a lot of times people feel that it's important to get someone out of bed and into a chair, and that is true. But the pressure in a chair is actually a lot greater than in bed. And that's why it would be important to limit the time out of bed if someone actually has a pressure sore. Also, if someone has a pressure sore, to avoid positioning on that pressure sore. We see so many situations where someone has a pressure sore and we look at the records and they're still lying on their back in bed for hours at a time. When someone has a pressure sore, it's especially important to position on the right side, the left side, and to have the facility come up with a turning and positioning schedule that is specific to that resident to address their current situation. And of course, proper treatment to heal wounds as soon as possible. And there are different treatments depending upon the stage of a wound. And I'm not sure if I mentioned, but wounds are stage 1 to 4, 4 being the most serious. And just that caveat at the bottom that each resident's particular condition will determine which of these interventions would be appropriate for them. Another situation we hear far too often is falls, people falling in nursing homes. And what we're hearing is leading up to a serious fall often is that someone fell multiple times and they were fortunate. They weren't injured in those other falls, but they kept falling and ultimately broke something, unfortunately. Or the facility is advising the family that someone's getting up and they're not pressing the call bell. Well, if that's happening, that's a red flag, and I'll talk about that in a moment. As I mentioned before, families are seeing unexplained bruises. Again, ask questions about that. And again, a common misconception that I like debunking regarding falls is that, well, residents are frail, they have unsteady gait. We can't help it, they're going to fall. Well, that leads me to the next slide. And I'm happy to share with you that there is also a regulation subsection under the quality of care regulation regarding accidents. And again, it's powerfully worded that the facility shall ensure that the resident's environment remains as free of accident hazards as is possible. And number 2, I feel like is so important. Each resident receives adequate supervision and assistive devices to prevent accidents. So again, this is their obligation under the regulations. So you may be thinking, Also, well, how can falls be actually prevented? Well, I like sharing with you some possible interventions. One is a low bed. And a low bed is actually different than a bed in the lowest position. A low bed goes even lower than a bed in the lowest position. And the mindset being that if someone falls out of bed, a low bed will allow them to fall a shorter distance than if the bed was in a regular position or a bed in the lowest position. Mats on the floor. If someone is not able to walk and is at risk for rolling out of bed or falling out of bed, then mats on the floor would be there to, if a person does roll out of bed, cushion their fall and hopefully prevent any type of serious injury from happening. Another intervention, bed alarms, chair alarms. We've heard a lot in the last few years. They're restraints. We can't use them from facilities. But as our experts tell us, that's not the whole picture. Yes, an alarm can be a restraint, but not every resident, it's only a restraint if when that alarm goes off, the resident stops doing what he or she was doing before. If the resident doesn't stop doing what they're doing when the alarm's going off, then it is not acting as a restraint for that resident. If the resident does stop what they're doing when they hear the alarm, there are alarms that are available that go off just at the nurse's station, so the resident wouldn't even hear it. And there are also alarms that go off on the staff's phones. So again, the resident doesn't hear it. And the mindset behind the alarm is that typically residents aren't getting up and jumping out of bed. The alarm is meant to alert the staff that a resident is potentially on the move, trying to get up and to get in there before they actually get up and suffer a fall. Toileting schedule is also so important because so many of the falls that we represent families for in our office are around a resident getting up to go to the bathroom. And it really makes sense because for all our lives, if we have to go to the bathroom, we get up and we go. And if someone has a cognitive decline, Alzheimer's, dementia, even though they're told, call us, press that call bell if you have to go, 5 minutes later, they don't remember that. And the purpose of a toileting schedule is to anticipate someone's toileting needs, to toilet them before they have the need to go, so they're not getting up unattended and injuring themselves. Also, our experts say to us that leaving a resident who is awake with cognitive issues in bed unattended is a recipe for a fall. So I share that. Non-skid socks for obvious reasons. Also, if a resident is at higher risk for falls, maybe they've been getting up, moving their room closer to the nurse's station so that the nurses can have a closer eye on the resident. And again, these interventions are examples. Each resident's particular needs will dictate which interventions are appropriate for them. Something else we see far too much of is malnutrition and dehydration. We see examples of a resident losing a lot of weight, 20 pounds, for example, and it not being investigated. A facility has an obligation to investigate unintended weight loss for a resident. And again, as I was saying before, don't just assume something is from something occurs because of someone's underlying illness or diseases. The facility has to investigate why is the resident losing weight. Also, we hear I feel so just heartbroken when I hear this, that a family will visit and someone's food tray was delivered, but it was too far away for the resident to actually even reach it and feed themselves, which is just, of course, completely unacceptable. We also hear situations of staff removing the food tray when the food tray is only half consumed. If staff is busy, they don't have time to finish feeding someone, or the resident needs help with finishing eating their food. Unacceptable that would be happening and the resident isn't getting the care that they need. And again, I want to share with you that we have a regulation that also deals with nutrition and hydration. And it is similarly powerfully worded with the word ensure. And basically, the facility has to ensure that someone maintains their acceptable body weight and protein levels and hydration. So similarly, I want to share what are some interventions to make sure that someone does have proper nutrition and hydration. As I was mentioning before, if someone has an unintended weight loss, what it has to be investigated. One of the ways of investigating that would be a speech and swallow evaluation. And that is done to determine if there is some physiological reason why someone is not eating the normal amount of food that they previously were able to consume. Also, some obvious things like just providing the resident with foods that they like and not giving them foods they don't like. As I mentioned before, taking the appropriate amount of time to feed a resident if they need assistance. Another test or investigation that could be done is a 3-day calorie count to actually determine what the resident is consuming from a caloric and protein standpoint. Supplements can be given if a resident isn't getting enough calories or protein. Also, a resident may be depressed, and that may be why they're not eating. And so they would clearly benefit from a psychological evaluation to determine if they can get help with that depression, and maybe there are medications that would be appropriate to assist. And lastly, artificial nutrition or hydration. As I mentioned before, these interventions are just examples, and it's important to look at the resident's particular condition and situation to determine which would be appropriate for them. If abuse or neglect does occur, it can be reported as I'm going to explain. First, it can be reported to the New York State Department of Health. And on the slide, it shows a website where the complaint form can be obtained, and it can be submitted. If someone wasn't able to go online, you can just call, actually, at the number that I have listed. I'll just read it in case anyone needs it. 1-888-201-4563. The complaint form can also be filed online. It can be printed and mailed to the address on the slide. It can be faxed. It can be scanned and emailed. So there are a lot of different ways. I've certainly hear people frustrated if I give someone advice to file a complaint, they'll say, well, I filed other complaints and I don't feel like my complaint's taken seriously with the Department of Health. And I do have my own frustration with complaints with the Department of Health, but that doesn't mean we should stop doing it. The Department of Health is the agency that regulates nursing homes and oversees nursing homes. And so they need to know if what is going on in facilities. So don't give up. Keep filing complaints if you are concerned about the quality of care that someone is receiving in a nursing home. And as is noted there at the bottom, that they will typically only consider complaints if an incident has occurred in the last year. So don't wait to file it as soon as possible. A complaint can also be filed or reported to the Medicaid fraud unit of the New York State Attorney General's office, and a link is there in the PowerPoint. Also, you can call and file a complaint with the Medicaid fraud helpline. Also, nursing home staff. If you're concerned about something, absolutely report it to the nursing home. You can report it to the social worker, to the director of nursing, the administrator. Don't give up. If you're concerned about something, as I was saying before, go with your gut and don't be deterred. If you feel like you're not getting answers, just keep going up the chain of command until you feel that your concern has been properly addressed. And of course, the Long-Term Care Ombudsman Program is another very important resource to file complaints or to get, not to file a complaint, excuse me, but to report abuse or neglect to. They are, as I mentioned before, there to assist between residents and facilities, to act as an intermediary, and they can help address problems. They can also help file a complaint with the Department of Health. And I have listed a link there. If you're not sure who is your ombudsman, you can use that link to find out, based on county, who the director is of the county program. And from there, you can be put in touch with your local ombudsman. As I mentioned before, the word surrogate decision maker. We're very lucky in New York to have this statute, the Family Healthcare Decisions Act. And that would come into play if a person, resident, is no longer competent to make healthcare decisions and they did not prepare a healthcare proxy and they don't have a guardian of the person appointed. This act would kick in and set forth a priority of who be able to make healthcare decisions for the person. And so it's really important we have this because if without it, someone would have to have a guardian appointed of the person. So this is really important, and it's important people know about it because at a nursing home, for example, if there is no healthcare proxy and the nursing home says, well, we can't talk to you because there's no healthcare proxy. Well, yes, they can, because there is the Family Healthcare Decisions Act, and the person who would be designated under this act has similar authority as a person would under a healthcare proxy, and the person is called the surrogate decision maker. And that concludes the topics that I wanted to discuss with you today. As I noted in this slide, we absolutely welcome residents and families to contact us with questions or concerns that they might have regarding a resident's rights or care. On our website, yournyadvocate.com, we have answers to some frequently asked questions. And again, we're glad to help in any way that we can. And thank you so much for your time and attention today.
Deb, thank you so much. That was really wonderful and so thorough and on point. I really appreciate it. As always, I learn a lot when I hear from you. If anyone has any questions or comments for Deb, we have a few minutes to she'll call it to address them.
Richard?
Yes.
Oh, okay. I'm going to stop. I've got to stop my screen sharing here.
Okay.
Oh, there we go.
There you go. Hi.
Okay.
Oh, so Maureen White asked, can you elaborate on the power and or limitations of the ombudsman, please?
Well, that's a good question. And Richard, you may be better able to answer that than I'm able to answer that. But, what can they do? They can look at records for residents. They can't compel a nursing home to do something, but they can certainly act to address concerns that families have. And I know that's a general answer, but maybe Richard, you could.
Oh, sure.
Speak better to that than me.
Well, I mean, I think from our perspective, the ombudsman program. So the ombudsman, as Deb was saying, they can't force a nursing home to do something the way the state Department of Health can. They can't penalize a nursing home. However, the ombudsman are really the only ones that are there on a weekly basis or monthly basis or so, depending upon the facility. They're the ones that can come in if someone calls the program and provide assistance right away. So they can be really helpful in navigating some of the things Deb was talking about in respect to raising a concern or complaint with different members of staff and or leadership in a nursing home and beyond the nursing home. They can help with filing a complaint with the Department of Health, et cetera. So in my view, they can be tremendously valuable for a resident and their family. One thing actually in regarding to complaints, I just wanted to mention that, as I said at the start, we do a lot of work with data, and I 100% agree with Deb and know personally that it could be very frustrating to file a complaint with the Department of Health and not get a response, or you get a response and your problem is deemed unsubstantiated. However, I think it's really valuable to know that the states in general, and I believe including the New York State Department of Health, they're much more likely to identify a problem through a complaint than they are through a regular survey. So it really does make a difference, even though it may not seem like it makes a difference to you immediately. It's a valuable thing to do. And thank you, Maureen. Janine, you ask, how can family members help increase the pay for CNAs in nursing homes? We need more CNAs.
Well, that it's a great question, and it brings into some other different topics, including I think there is a misconception put forth by facilities, by owners of facilities, especially for-profit facilities, that they just don't have enough money. They need more funds in order to pay people more and to be able to continue operating nursing homes. And in from the information I have and my understanding, that's just not true. They're making conscious decisions about how to spend and how to allocate the money that they are receiving from the Medicaid program or private pay or Medicare. So I think that it's a great question, an important question, and a difficult question because I think most facilities do need more staff. And so how do we accomplish that? I think by advocating for better care in nursing homes and speaking at the nursing home, if the facility says, well, we don't have, I've heard actually staff say this, well, we're told by management that that they're not getting enough reimbursement to hire more staff. Well, that's, I would really question that. And I would, when you make a complaint at the facility about your loved one not getting proper care, then say, well, we need more staff. And if they say, well, we don't have enough money to hire more staff, say, well, based upon the advocacy work that you are doing as an individual and that you're reading, that's just not true. And also, facilities should not be accepting residents if they don't have enough staff to care for them. Years ago, I would never hear a family say, a staff member told me, we just don't have enough staff to do something. I've had families be told when they want their loved one to be changed and they're not changed for 2 or 3 hours, well, we don't have enough staff. Well, that's an admission that they're violating the regulations, because even before we had minimum staffing regulations in New York State, and there is always a requirement to have sufficient staff to care for residents. So I don't know if Richard, you want to add anything?
No, that's a great segue actually to the next part of the program, which I'm going to talk about some of the data, the staffing data in particular. So let me see if I can get to my slides. Here we go. So some of the things, this is just really some general background in regard to data. So these programs for the Hudson Valley are really focused on 2 things. One, a residents' rights portion, as we just had with Deb, and then a data portion to give people, families, ombudsmen, the legislators, legislative aides, et cetera, information on relevant data related to what is going on in nursing homes. So what are we talking about here? I'm going to go a little bit quickly because we only have about 15 minutes left. But we're talking about staffing information. I'll talk more about that today. We're talking about enforcement information when a facility has been cited for some of the things that Deb talked about and beyond. Ownership and financial information. Again, getting at some of the issues Deb was just, talking about in response to Janine's question is, how is this facility, how are facilities and, your facility in particular, how is it being operated and is it being run with integrity? Meaning that, as Deb has said time and time again, there are certain requirements to operate a nursing home. And when a facility agrees or an operator agrees to accept Medicare and Medicaid patients or Medicare and Medicaid patients, excuse me, then they agree to meet or exceed all of those standards. And there's just no excuse whatsoever for saying that you need more money to hire more staff. It's just not a legitimate response. And as Deb said, and it's just something that really bothers me, is that, a facility, when they don't have enough staff to do something, they should not be accepting new residents. That to me is the most fundamental requirement of the nursing home law, both state and federal, is that you're not operating a warehouse. You are operating a nursing home for people who, by definition, need 24-hour day skilled nursing. And then lastly, we also provide a range of performance information, some of which actually we'll talk about today, although we're focused on staffing. But why are these data important for us? Well, they're really important for everybody, as I note here, from residents and their families to the providers themselves, who should be looking and are actually required under the federal rules to be assessing on an ongoing basis the extent to which they have sufficient staffing and other services to meet the needs of their residents in accordance with the rules that Deb has spoken about, and of course, which you could find resources about on our website. And they're important to policymakers. And that's why, we consistently say in these programs, please use this information to contact your policymakers. We encourage legislative offices to join us for these programs. They are recorded on our website and on our YouTube page. And of course, they're useful for advocates, including long-term care ombudsman and offices such as LTCCC, to advocate, to provide a basis that people can understand for why we need systemic change in nursing homes. So today's focus is going to be on weekend staffing. This was actually inspired by some questions raised by ombudsman that I was speaking to. And this is something we hear all the time. I'm a family member myself of a nursing home resident, that staffing is much lower. It tends to be much lower on weekends and on holidays. And, nursing homes will use that as an excuse. So it's a weekend, oh, it's July 4th, oh, it's Christmas time, etc. However, two things I note here is that one, nursing home residents' needs don't change on the weekends or on holidays. The resident has needs as defined, identified through their resident assessment and through their care plan. Those needs are every single day of the year. And importantly, nursing home payments don't change. So to say you're only going to have, you're going to have lesser staff on Sundays and Saturdays or July 4th, et cetera, because because you're having difficulty finding staff, well, you're getting paid the same amounts. So what kind of incentive are we providing when we allow facilities to have less staff on the weekends? Nevertheless, it's a persistent problem. And then, the other issue that we hear all the time is that nursing homes say, as I've said, that they, staff call out, they have trouble finding staff to work on July 4th or on weekends, et cetera. And this always really amazes me, because most of the nursing homes, if not virtually all the nursing homes that I've been involved with over the years, have been around for generally decades. I mean, this is not the first time they had a Christmas. This is not the first time they had a July 4th or a weekend. And as responsible business owners, they should be planning in advance for those things to happen. So, why does weekend staff matter? Or does weekend staff matter? And yes. So I just wanted to provide a couple of charts, excuse me, showing you these are the data from nursing homes. Again, this is, a data visualization. And this shows that you can see the left-hand side is the number of hospitalizations per 1,000 long-stay nursing home residents. And then the bottom line, excuse me, is weekend RN hours per resident per day. And then you can see from left to right, as weekend RN hours go up, the number of hospitalizations go down. And I'll move, excuse me, quickly, please. Sorry, I have a frog in my throat. Same thing in terms of as weekend RN staffing goes up, the percent of residents who need help with activities of daily living goes down. Same thing with antipsychotic drug use. As Deb said, many of those drugs are dangerous and they're not indicated for so-called dementia-related behaviors, et cetera. This is a major issue for nursing home residents. As weekend registered nurse staffing goes up, the use of dangerous antipsychotics goes down. So over and over and over again, we're seeing this correlation between higher staffing, especially higher RN staffing, registered nurse staffing, and lower indicators of poor quality. So I wanted to talk a little bit about, well, what does this mean? What does this mean in terms of nursing homes in general? And how do we approach this? Well, one thing is, as Deb said, or hinted at in response to Janine's question towards the end of her piece, is that, we too often just don't know where the money is going when we pay a nursing home for care, whether it's us as individuals, insurance companies, or most care is paid for through Medicare and Medicaid. But as we can see here, looking at for-profit versus government-owned facilities versus nonprofit facilities, is that for-profit nursing homes have 25% less weekend staffing than government-owned facilities and 20% less staffing than nonprofit or charity-run facilities. So ownership matters. Not every for-profit is bad. Not every government or nonprofit is good. But generally speaking, you have, with the government and nonprofits, you see more money being put into care, and in particular, more money being put into staffing. Again, getting at some of those underlying issues that Janine first raised. Same thing with RN nurse, as we're looking at weekend staff. Does ownership matter? Yes. And here it's really a lot. For-profit nursing homes have over 50% less weekend RN staffing than government-owned facilities and 40% less weekend staffing than nonprofit facilities. So it's really quite striking. And keep in mind, when we talk about for-profit, these are companies that have invested in the nursing home sector because they are making money off of it by definition. So when they turn around and tell their customers, the resident, the family member, the legislator, et cetera, that they don't have enough money to provide better care or they need more money, that's just false. Again, these, by definition, the for-profits are coming in and they're making profits off of nursing homes. So I wanted to look specifically and provide everyone with some data that they could use in your day-to-day work, whether you are helping residents, whether you are a resident or a family member in a specific nursing home, etc. So this is, again, looking at the weekend versus weekday staff just for Hudson Valley nursing homes. And you can see here a significant difference between weekday nursing home staff and weekend nursing home staff in our Hudson Valley nursing homes. Same thing with RNs. We see a substantive difference between weekday staffing and weekend staffing for RNs. So, these charts are interesting. I think, they're very, by being graphic, they really do send a message and could be useful when talking to legislators, when talking to county officials, again, your state legislators or your congressional members of Congress. This is all really important. Where do we get the actual data? Well, I'm going to talk about that next. But before I do that, I want to just mention, to keep in mind a few things. One, all nursing staff are important. Nursing home care is provided by RNs, LPNs, which are licensed practical nurses, and CNA, certified nurse aides. Certified nurse aides provide roughly about 90% of bedside care. Most of the rest is provided by LPNs, but RNs are essential because RNs are really the only one typically in a nursing home who has the ability to oversee care, to manage medications, to ensure that the care provided by CNAs and LPNs is in compliance with the both professional standards and the nursing home rules. And it's really only the RN who has the training and the licensure to evaluate a resident on the clinical matter. So the RNs are essentially important. And as I note here, study after study have shown that there is a very important correlation, perhaps the strongest correlation between RN staffing levels and resident safety and quality. Nursing homes are required to have an RN in the building at least 8 hours a day. That includes weekends, that includes holidays. The rest of the day, the other 16 hours, can be provided by either an RN or an LPN, but nursing homes are required to have professional nursing staff, either an RN or LPN, again, 24/7, 365. And then, as Deb said, also, irrespective of any state requirement, irrespective of any federal requirement, it is, in terms of a numerical number, or having 8 hours of RN staffing, or New York now requires 3.5 hours minimum of nurse staffing per resident per day. Irrespective of that, nursing homes have been required since the early 90s to have sufficient numbers of nursing staff with the appropriate competencies to provide quality, safety, and dignity for every single resident in the building, no matter who pays for their care. So I want to move on and show some specific data. I decided to focus here just to make it as simple as possible, because there are a lot of nursing homes in our region. I just focused on Dutchess County nursing homes here, but we can do this for other counties. We could really, have the data any way that you're interested. If you're an ombudsman program, or if you're meeting with the legislator, or if you are a legislative office, we can be happy to provide you with the data in a different, different types of data for different nursing homes. But this shows Dutchess County nursing facilities, their total nurse staffing, which is in the orange, versus their, total nurse staffing as opposed to the weekend staffing. And so you can see the weekend staffing is lower, lower, lower as we move along for all of these facilities. And you can see the variation in the facilities. For instance, it looks like the Pines at Poughkeepsie is one of the higher range facilities in the blue. Sapphire is a little bit lower. This is for overall staffing, RNs, LPNs, and CNAs. Did a similar graphic for the RN staffing, total RN staffing versus weekend RN staffing. Here you can see some profound differences. For instance, at Sapphire Nursing and Wappinger Falls, higher, much, much higher for weekday, and very, very low on the weekends. And then you can see some facilities such as Renaissance Rehab and the Eleanor, which are just low, period. And there's, in many ways, only so low you can go, because they're really required to have an RN there, as I mentioned, a few moments ago, 8 hours a day, every single day of the year. So if they're, if they're not staffing up above that to provide appropriate care, then you'll see low numbers, but it's only so low that it can go, thankfully, I guess. But you can see this provides, again, a graphic of what is going on. How do you use that information? Well, we have data that we put up on our website, and we have a special dedicated Hudson Valley page, thanks to this grant and support from the Field Hall Foundation, from the Dyson Foundation. We put this data up. So this is an Excel file. It's kind of a snippet, but you can see in this Excel file, we have the provider name, Sapphire Nursing, Wappingers here, their address, what city they're in, their zip code, their telephone number, and then the reported RN staffing per resident per day. And then here, the last two columns are the total numbers of nurse staffing hours per resident per day on the weekend. And then lastly, the RN hours per resident per day on the weekend. So you can take this data in a form that is, showing you the actual numbers rather than some of the charts that we saw before. You can take both of them and use them to address issues, whether within your facility or, again, within your community and with community leaders. That provider data set, as I said, that was just a snippet of it. But what it includes a name and the phone number for the facility, includes what type of ownership it is. As I mentioned before, we see really big variations between for-profit and not-for-profit and government-owned. Whether it's affiliated entity means that it is part of a chain, and we do see a lot of chain ownership in the Hudson Valley. It's something we could talk about in a future program. Whether it has been cited for abuse or is a special focus facility, meaning that it is one of the worst facilities in the country. Its ratings over the last 3 years, the citations and fines and substantiated complaints against all of them. And the links I have here, the top link in orange, that's for the entire country. It's a searchable file, so you can look at New York in particular, you can look at other states, and then you can look from there at specific counties. Or if you just wanted to go to the Hudson Valley, I have the link to the Hudson Valley here as well. Our next program will be on October 9th, again at 11 a.m. We'll do a data update, and then we're going to talk about filing a complaint, how to do it, where, with whom, etc. So hopefully to provide, you all and the people who you're working with usable tools and information on how to file a complaint as effectively as possible. I know we're running long on time. There might have been a couple of questions. Here are our links to our various social media. Please email info@ltccc.org if you would like to suggest a topic for a future program. And thanks again to the Dyson Foundation and Fields Hall Foundation for supporting these programs. And please spread the word, because we want to make them short and meaningful for the community, and we'd like to get these resources and information out there. So thank you. I don't know if there was any questions. I guess I don't see any.
Richard, actually,
yeah.
sorry, there is
Okay.
actually one question in the chat from
Okay.
Nancy. It says, how is the budget reconciliation bill going to impact minimum staffing requirements?
That's a great question. So the budget reconciliation bill, I mean, a lot of people are concerned about it, and rightfully so. We're talking about the federal budget that was passed a couple of weeks ago now, because it does have very, very, very substantial Medicaid cuts, and most nursing home care is paid for through Medicaid. However, the nursing home owners, and therefore the nursing home residents, were really protected in this law by the way in which the cuts will be implemented. So nursing home care under Medicaid is what's called a required benefit, is that states have to provide nursing home care, and therefore the monies going to nursing homes haven't been cut. In fact, nursing homes are getting a raise next year. I think it's 2.6%. I don't know if you remember offhand, Hallie, but I think it's 2.6%. So, they're getting essentially more money, and they get a lot more money from Medicare as well. Medicaid rates are going up, Medicare rates are going up. So it's not a problem for nursing home residents. And certainly not a problem for nursing home facilities and operators. It's really a problem more for people who are accessing care, or will be a problem, excuse me, for people who access care outside of nursing homes. Like in New York, we have what's called an assisted living program that enables some people to get care in an assisted living facility who qualify for nursing home level of care, but they're able to live safely, outside of a nursing home. Those kind of benefits, also home care benefits, home care Medicaid benefits, those are not guaranteed benefits. And so I believe, it's my assumption that a lot of cuts will happen there, and that'll put further strain on assisted living and on home care and those sectors. But nursing homes will be pretty safe. At the same time, that budget bill, it delayed implementation of the nursing home staffing requirements, the federal nursing home staffing requirements, for 10 years. So those staffing requirements have been up in the air. There are two court cases, one in Texas and one in Iowa, both of which the judges have at this point ruled against the Biden nursing home staffing standard. But for New York, we do have actually a similar standard that was passed, I believe, over 2.5 or so years ago now, that requires somewhat similar 3.5 hours nursing staff time per resident per day. Unfortunately, to our knowledge, there's been no implementation of that requirement. So facilities have not been penalized when they don't meet that requirement. And that's obviously really shameful. Those are very low requirements. So we come back, and I'll try to wrap it up here with what Deb said earlier. And what we always say is that the law requires that nursing homes have sufficient staff with the appropriate competencies to meet the needs of their residents, their clinical needs, their psychosocial needs, etc., so that they can live and attain, but I'll give you the language pretty much exactly, so they can attain and maintain their highest practicable physical, emotional, and psychosocial well-being. So that matters, that exists, whether or not there is a state requirement, numerical requirement of 3.5 hours, whether or not there's a federal requirement of 3.48 hours, etc. So I hope that was helpful. Thank you all very much for joining us. Please do let your communities know about these programs. We really want to we're doing them because we want to make them as useful as possible to help people in the Hudson Valley improve care and quality of life for their residents. And Deb, thanks so much again for joining us today. Really appreciate it. As always, really nice to see you. Thank you, everybody. Nice to see you.
Welcome, Richard. My pleasure for everyone.
Bye-bye.